should now be live for week 2 of Joint School Live. We're still in quite strange times, although it's a beautiful day here in London, and I hope you're all keeping well and safe out there. This week, I'm very excited to again be joined by Helen also, a physiotherapist who was with us last week, and this week she'll be progressing some of the home workouts and exercises that she introduced last week. And I'm also very honored to be joined by Brogan Guest, who's a physician associate who's been working with Professor Justin Cobb for the past 3 years. And she also lectures on the physician associate program at St. George's University here in London. And a little bit later, I'll also have a bit of an extra special interview with Beverly Weber, who will be sharing some of her tips and thoughts on her experience of having a hip replacement in her 40s. So action-packed for week 2 of Joint School Live. And I will just bring in Brogan now as well, so that we're all here together. Let's see. There we are. Super. Welcome, Brogan.
Hi, thank you.
Now, so physician associates have been really a core part of the healthcare system generally in the US for quite some time. But here in the UK and perhaps elsewhere in the world, it's perhaps a role that some of our viewers might not have encountered as yet. So just in a sort of a quick overview, what does the physician associate role kind of entail? How do you fit into the orthopedic team or any other team?
Yeah, sure. So physician associates are part of the healthcare team, and they're trained medically. So after graduating from university, physician associate students enroll in a 2-year PA program. The first year they spend learning about medicine in a classroom, and the second year they spend in hospitals and in clinical settings, still learning. After graduating, they can work with supervision under a physician, and they perform many of the same tasks that physicians do. They diagnose patients, they may order tests, and they can help design treatment plans. PAs are becoming more common in the UK, and you may start seeing them either in GP setting or even in hospitals.
Okay. Well, neat. Good stuff. Well, thank you so much again for joining us, Brogan.
Yes,
really exciting to have you part of this project. And today, because it's something that's often covered sort of in the early stages of a joint school session. When I was doing these in hospital, it would be kind of the first things after a bit of an introduction would be to give an overview of arthritis, because that's the real culprit in the drama, so to speak.
The reason we're here.
Yeah, exactly. It's very much the reason we're here.
Yeah. So there are lots of types of arthritis. And in general, when you hear someone say they have arthritis, typically what they mean is osteoarthritis. Sometimes you'll hear it as osteoarthritis or degenerative joint disease or even bone on bone. And so what this means is normally our bones are covered with a nice layer of cartilage between the joint. The cartilage helps to cushion the bone and support the joint. What happens in arthritis is this cartilage gets worn away, usually through overuse. And this is what you'd hear described as bone on bone. So instead of having a nice cushion in between the bones are closer together. And when the joints move, they can rub on each other. And that's what causes a lot of the symptoms, the pain that we see in arthritis.
And I guess there's an interesting point there about it often, not always, I guess, but often being related to overuse. And yet, people who are in this difficult situation will often hear, healthcare workers such as ourselves recommending them to keep active and keep using their joints. And I guess that can sometimes sound a bit counterintuitive.
Yeah, it can be confusing. So it's tricky. So with weight-bearing joints, so knees and hips mostly, that's where a lot of patients have arthritis. We want these patients to stay active because staying active is good for your physical health and it's good for your mental health. But I caution against doing exercises that aggravate your joint pain. So anything that's weight-bearing or really high impact, doesn't necessarily benefit the joint. So we're always pushing lower impact activities. So things like cycling or things like swimming, where the body weight isn't being forced through your hip and knee. Those tend to be things you can do throughout your life, even with arthritis, that can still keep you mentally and physically active. So when we say to keep active, we're not always meaning to run necessarily or to put a lot of weight through the joints, but doing activities that you still can despite the pain.
Mm-hmm. Yep. And you touched on some of the symptoms. I'm sure many people who are tuning into this will be well aware, but perhaps a quick overview of what arthritis can then result in, sort of, so to speak, when it starts affecting a joint.
Yeah. So it varies a lot between patients, actually. So some patients, their main complaint is that they have a lot of pain, while other patients, they'll have a lot of stiffness or feel like the joint can't move. Many will have a decreased range of motion. So maybe the knee doesn't bend or flex fully, or maybe with your hip, you won't be able to bring your knee to your chest or tie your shoes and socks. Some patients have swelling or redness of the joints and some don't. So it really varies. Pain, stiffness, swelling, all of those things can occur.
And with these symptoms, once these kind of symptoms begin, and you might see a GP and then an orthopedic surgeon or some other physician and so on, and then be given a diagnosis of arthritis, does it always get worse?
So it typically doesn't get better. But it doesn't always get worse. So unfortunately, there's no way yet for us to regrow or regain cartilage. So I talked about arthritis as being a loss of cartilage between the bones, and cartilage is a tissue that doesn't have a huge blood supply. So it's really hard to regrow it and get it back. So once it's worn away, it's pretty much gone. So although we can't reverse arthritis, there are a few things we can do to help make the symptoms better. So, and there are things that you could do to make it worse. So if you want to make your arthritis much worse, you could do lots of weight-bearing activities like running, weightlifting. So there are ways to make it worse.
You could take that as bad advice.
Bad advice, yes. So activities that stress the joint will make it worse, because this is usually an overused thing. So activities, like I said before, that are low impact, that are non-weight bearing, swimming, cycling, stretching, all of those things that can help. And really, the gentler you are on your joint, the more life you may be able to get out of it. So things like, if you're having a particular bad day, using a walking stick or using a crutch can really help. And keeping a healthy body weight is huge. So the joints that we're talking about that have arthritis mostly are knees and hips, and all of your weight are on these joints. And so even losing a few kilograms can make a big difference in the amount of symptoms you feel. So it's the difference between walking with your body weight, or if you'd imagine carrying a 10-kilogram sack of potatoes everywhere. You can imagine after a week, your knees and hips would be really sore. So if you lose that, just losing a little bit of weight can really help the symptoms.
Yeah. No, and there's some really interesting studies on human movement and kind of the biomechanics and the physics involved in and how the pressures are distributed across our joints when we move. And there was one I read a couple of weeks ago where during squatting, I think the knees can take up to 5 or even 6 times your body weight because of how the pressure is increased through certain movements. So just through some everyday movements, you really, really can put a lot of pressure on. And then that means, so for every pound or every kilo of excess weight that you lose, of extra weight, that's 5 to 6 potentially gained on your knees and hips.
Right. And it is hard. It's a really hard thing to ask, especially when I'm telling patients not to do high impact activity. So we often think about maintaining a healthy body weight by exercising. So mostly it will have to be through diet. And it is a really hard thing, but it can really help with the progression and the symptoms of arthritis. Yeah.
And of course, it's also important to flag that this would only be relevant if you have some extra pounds and kilos to spare. So if you are already of an ideal weight, then it's not a good idea to sort of try diet on that.
Yeah, exactly. So keeping an ideal body weight.
Super. Okay. And I think one thing that, again, I guess is something that many people will be aware of about the sort of the typical person who has severe arthritis, but it does tend to affect older people more. But is that right?
Usually it does. So we think about it as a disease that increases with age. Because it's this overuse arthritis, it's about how many miles you've put on your joints. However, we meet a lot of young patients in orthopedics that need hip and knee surgeries. And young patients can get arthritis usually due to the shape of their joints. So the way that they were born, maybe the shape of their bones or the shape of their hips make them more at risk for arthritis. And these patients still tend to have put a lot of miles on their joints. So the shape of your bones and the shape of your joints can increase your risk of arthritis. And then, it's about how much you use them as well.
Yeah, and indeed, so Beverly Weber, who I interviewed and who will be posting that video, she had a hip replacement in her 40s, and I think that's certainly something that is not that uncommon, and I believe is even on the rise.
Yeah, we're seeing younger and younger patients as hip surgeries and knee surgeries become safer and the implants get better. We will continue, I think, to see younger and younger patients seeking relief of their pain.
Mm-hmm. Yeah. And there was something, just going back to a point that I think is quite important, that you raised about how the cartilage around the joints don't really have as good a blood supply as other parts of the body, and therefore are not as good at healing, essentially. And I suspect that's something that many people who are now in the position where they are awaiting a knee replacement or a hip replacement, or indeed if they've already had one, may in the past have had injuries to their knees or perhaps even to their hips involving cartilage, such as injuries to the menisci or the meniscus, which are these sort of cartilage weight-bearing things. And it's exactly those kind of knee injuries can take a really long time to heal. And again, that's because of this slow blood supply, or not quite as good blood supply as you'd have in the skin and other places.
Yeah, exactly. And a lot of the patients that we see that are young that require hip and knee surgeries have had injuries to their cartilage or to their meniscus. You may have heard of labral tears in the hips.
Mm-hmm.
And then when these injuries happen, they do heal, but they heal in a way that puts patients at risk for later arthritis.
Mm-hmm. Yeah. And so we talked about how it is becoming, these operations are becoming more common among younger people, but is still perhaps, with it being partially an overuse, being more common with age. But is there a split between the genders? Is it more common?
Yeah, so when we think about general osteoarthritis, overuse arthritis, it's pretty even between men and women. There are other forms of arthritis that are much more common in women, types of arthritis such as rheumatoid arthritis or other inflammatory conditions that are caused by autoimmune diseases. And in general, autoimmune diseases affect women more. So women more often get inflammatory type arthritis like rheumatoid. But when we talk about this general overuse arthritis, especially in the knees and the hips, it's pretty evenly matched between men and women.
Okay, yeah, that's interesting. And I think I've read something also about how, unfortunately, in some cases, women may be more likely to sustain injuries such as while playing football or soccer to the knees than men, just because of some subtle variations in anatomy, and that can then predispose. If you're more likely to have these types of injuries, then perhaps you're more likely to develop the potential consequences of that, such as this severe arthritis. And so, how, I guess this is in some ways may not be a straightforward question. So I seem to be prone to ask sort of quite general, unspecific questions. But how does one know when it's time to have a hip replacement or a knee replacement?
Yeah, so something that I always remember is that every patient is different, and that knee and hip replacements are elective surgeries, and that means that patients elect or opt to have the surgery. So it's not a life-saving surgery that needs to happen. It's really a decision between the patient and the surgeon of when it's time. So every patient will elect to have a surgery at a different time. In general, I tell my patients to start thinking about having surgery when the joint really starts to affect their life on a daily basis, and then they've tried other things and those things are no longer helping. So some of those things we've already talked about, things like weight loss, if you have excess body weight to lose, muscle strengthening, getting good sleep, taking medications perhaps to help with the symptoms, sometimes even injections into the joints. So all of these are things you can try before we go down the path of surgery. When those efforts fail, however, patients can start to think about considering surgery. So some patients, I think, opt for having surgery when, for example, they have a lot of pain at night and they're no longer able to sleep, or maybe when the pain is prohibiting them from doing activities they love. So it's really varies, and patients also have a different threshold for pain. So the decisions, it really tends to need a discussion between the surgeon and the patient, and everybody's timeline for readiness will be different.
No, absolutely. There's some really good points there, and a lot of those kind of different tools and approaches that you can apply to try to help manage your own situation and your symptoms will be available in the Joint School app, and in such a way that you can track progress with different symptoms. You can track your exercises, keep a pain diary, and different tools that we know different people find helpful in terms of trying to gain control of your symptoms, and also understand perhaps how they change over time, and also how, while everyone is different, and ultimately this is a decision, for each person to make about having surgery together with their surgeon. It can still be useful to get a feel for how your situation compares to someone else who's in a similar situation.
Yeah, and I think it's a really nice opportunity for patients to be able to track their symptoms. So we don't really have much memory from, 6 months ago. So when I ask patients, are you much worse or much better than you were last year at this time? That's a really hard question. We tend to only kind of remember our symptoms as they are right now. So if there's an objective way that they can look back and say, actually, I was much worse last year, and now these changes that I've made have helped, or actually last year I walked a lot more steps and had a lot less pain, and so things are definitely getting worse. And I think just having that picture and an objective data can help them make a decision.
Yeah, absolutely. I mean, I've absolutely found that myself, both from personal experience with chronic pain, in terms of how quickly you can forget the bad weeks. And so when you look back on maybe an old video or an old photo and you kind of see positions like, wow, this is pretty bad then, I'm not thinking about that. And equally, when I was working in orthopedics in a hospital here in London, often when you did the follow-up clinic after a knee replacement or hip replacement, and you looked through the notes of describing the kind of situation someone was in before, not infrequently, they would kind of have reset the goalposts a little bit and kind of forgotten how bad things were, and are absolutely now aiming for bigger and better things. And in many ways, that's the outcome that you want, I guess, with someone really getting back into a level of activity that they did not have at all before surgery. But I think it can also be useful to have an objective measure of where you were and to see how things have changed.
Yeah, absolutely.
And to help enable that, something that has become has been increasingly recognized in the past couple of years is this idea that many might encounter with patient-reported outcome measures, or PROMs, or in the US sometimes just called PROs, patient-reported outcomes. And that's while we absolutely recognize that every person's experience is unique, these surveys are trying to define just that, trying to get an idea of, can we arrive at some kind of a objective measure that captures each individual's personal experience, but kind of then gives a ballpark of how that relates to a wider cohort or a wider group, matching gender, matching age group, and so on. And they're becoming a really important part, especially in orthopedic surgery. And I'd expect that pretty much everyone here, or everyone watching this who's getting ready for surgery, will be asked to complete some form of this type of clinical survey, be it the Oxford knee score, or the Oxford hip score. In the Joint School app, we've used another validated survey called the KOOS and the HOOS, and they'll be in the app to enable you to track your progress. But indeed, also with your surgeon, there will be a program to try to make sure that you are able to check in with those surveys before surgery, to kind of set that baseline, which is super important to understand where someone was before the surgery, and then at a few key points after surgery. And that can vary a little bit depending on the survey that a surgeon or department or hospital may choose to use. Increasingly, this is becoming more standardized, sort of in national registries, and so there's a move to everyone using the same surveys and the same kind of checkpoints. So that could be before surgery, and then It might be at 3 months after surgery, at 6 months, and a year, some variation around that. But the key thing really is to have a baseline to help understand what kind of situation someone is in before surgery, how they progressed, and ultimately sort of where have they ended up, so to speak, or how are they doing at 1 year, and perhaps even beyond that.
Yeah, and that's really, it's useful for patients to be able to see that, and it's useful for surgeons, and for us from a research standpoint, it's really interesting. So when patients complete that data, we really use it and are thankful for it. So it helps us decide which type of surgeries are better for patients. So I really think doing those scores benefits everybody involved.
Yeah, and I'm really hopeful that with the Joint School app, it's a way of kind of contextualizing these surveys and their role and what they can do with patients, with people who are most closely affected by them, rather than kind of ticking boxes in a piece of paper and sending it off in the post and not really getting a response back of what was my score, what does that mean, how does it relate, and actually what was my score last time around. And so in the Joint School app, when you complete the surveys, you'll see, all right, that's me on the graph before surgery, and this is where I am now after surgery. And indeed, for those who are now awaiting surgery and getting ready for surgery and might not have a procedure date, there's also surveys to sort of track your progress on a regular basis leading up to when you have an op date, and that can then be added in, and you kind of start on the pre-op pathway. There's a term that you touched on as well that it might be worthwhile just doubling back on a little bit, this idea of hip and knee replacement surgery being elective, because I think that's something that people will probably see more of if they haven't already in the news, in terms of how healthcare systems all around the world have had to reorganize and mobilize against the virus, and how, as hopefully it looks like we've seen the worst of it. Well, we're by no means through the woods as yet, but as we can start making a return to more normal practice, there will be a return to different types of surgery. There will be different types of priorities, and I think it's important to acknowledge that hip and knee replacement surgery generally is elective, which means that it's booked in. It's not emergency surgery, but sometimes I think it might feel a bit demeaning in a way as a term, because elective surgery doesn't mean that it's not important.
Right. Or that you're not struggling or don't have symptoms. Yeah, it is a term that almost sounds like you want to have surgery, and that's not what we mean. We certainly mean that it's not a trauma or an urgent surgery, that if you broke your leg, that would be a urgent surgery. But if you're booking in and you're coming to see us and you're kind of going through the normal procedure in order to have a knee or hip replacement, we would call that elective. And actually lots of surgeries are elective. So basically anything where you're booking and going to have the surgery is considered elective. I don't want to trivialize symptoms by calling it that at all. So we know, and a lot of times the pain from hip and knee surgeries or hip and knee arthritis, patients have rated it on these scales as being worse than death. And so we recognize that as healthcare providers, and we've had lots of conversations about what are we going to do during this period when people who are awaiting surgery are suffering, and it's a really hard thing. And so everybody, I think, is aware and is working on it.
Yeah, no, indeed. And so for people out there now who are waiting for a hip and knee replacement surgery, which can be a time of uncertainty and perhaps feel a bit daunting, at any time, let alone now. But what are the kind of things that one might do to help navigate the next steps?
Yeah, so it's going to be a stressful time and an unknown time, because you're right. We don't know when surgeries will return. And so the timeline is unknown, which I think is a frustrating thing. So the first thing is to recognize that it is frustrating and to allow yourself to feel that frustration. I think staying healthy mentally and physically is all patients can really do when they're waiting. So like I said before, there's really no exercises that can reverse the arthritis and make it completely better. So thinking about that, knowing that any activity that stresses your joint will probably make it more symptomatic or make it worse. So thinking about keeping your heart healthy and keeping your body healthy with those low impact, non-weight bearing activities is important. If you have a particularly bad day with your joint, using a crutch or using a stick to take pressure off the joint. I think for pride reasons, lots of patients, especially younger patients, don't like to use supportive devices like canes or crutches, but it can make a huge benefit and impact on symptoms. I also recommend getting good sleep, which may be really hard during this time, but poor sleeping and fatigue and tiredness can worsen pain and lower pain threshold. So in general, avoiding any activities that hurt your joint. So the more gentle you are with your joint, the fewer bad days you'll have. And then most importantly, I think if patients can either join support groups or can talk to others, knowing they're not alone, there are many patients that have had their surgeries canceled or delayed during this period. It's stressful, it's frustrating, and so anything that patients can do to reach out and talk to others to help manage their stress, hopefully will be helpful too.
Yeah, yeah. No, I think that's absolutely right. Absolutely right, and those key points are things that we're hoping to enable and enhance and emphasize with the app and the other resources that we'll make available. And we can post some links in the description to this video to some of those online groups and other useful resources, because there's quite a lot out there, and as you say, there's many people in this situation. So
yeah, exactly.
You're not alone if you're in this situation at all. Yeah. Super. All right. Well, Brogan, thank you so much for joining us today. I think that's been a really nice overview of arthritis and really sort of highlighting some things that I think can be really helpful for people in this situation.
Yeah, well, thank you. I enjoyed it. So thanks for having me.
Yeah, thank you. And hopefully we'll see you again before too long.
Yes, sir, of course. Take care.
Okay, everyone. Well, so that's it. We will tune out for now, and we'll be back a bit later with Helen Alsop going through some of the progressions of the exercises from last week. So until then, be safe, be well, and keep up the good work. Bye-bye now.